Please listen carefully.
Hello and welcome to GasGasGas, your one-stop podcast for the FRCA primary exam. This podcast will fill your brain with information. Listen to it, think about it, and check out the show notes on the website. There you will find the core diagrams you need to be able to draw and describe for the exam. This podcast can squeeze into your day. Listen while you're driving to work, cooking dinner, maybe when you're on call, or in the gym. Eventually the revision is going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Remember to rate and follow the show to hear much more. Hello everyone, this is James at GasGasGas. Today we're going to talk about fentanyl. Having already had a chat about rock uranium and propofol, it seems reasonable that the third component of your generic anaesthetic that might work for everyone with some tweaks would involve a chat on fentanyl. Very commonly used opiate, chiefly used as a co-induction agent for anaesthesia, and then you chase it up with some morphine, middling to halfway through your case. It's good for early or rapid perioperative pain control if there's a briefly exceedingly stimulating bit, i.e. jabbing that abscess that you're all rooting and excited to do. It's great for post-op pain control, actually. Its onset time is far superior to morphine, and its side effect profile seems to be nicer and kinder compared to morphine. People seem to be a bit more spaced, dizzy, nauseous with morphine compared to fentanyl. And this is in part because it has high specificity to the mu opiate receptor, which is the one that really does pain instead of making you feel awful. For me, I commonly reach for fentanyl as a co-induction agent. If you're not fussed if they're breathing or not, then give them the whole ampule 100 mics. If you're feeling, you know what, I want them to breathe quite quickly because it's a quick turnaround case and I don't want too much faff, then actually a mic per kilo or even a bit less than a mic per kilo and wait for the patient to feel it before you induce them will probably preserve them and their breathing more so. For example, one of the consultants I know just gives about 40 to 50 mics. To most people, waits for them to go, I feel a bit, that's nice, and then gives them the propofol. And they tend to breathe quite quickly, which is convenient because then you can start writing your notes instead of having to bag them or put them on pressure support or try and ventilate them and then have to fiddle with the ventilator again because they're starting to breathe. Other common uses for me, post-op pain control. Getting control of significant pain in resus quickly because you can give someone morphine and then you're twiddling your thumbs because it takes 30 minutes to reach peak effect, which is just bonkers if someone's in acute pain. Often you give morphine and the patient changes, i.e. they get a bit spaced or feel a bit green, and that's the effect that they sometimes have the titration of morphine to by people titrating at a milligram a time very carefully. I don't like morphine, I think you maybe get that impression. Fentanyl, bang it in, starts working within a couple of minutes, peak onset 5 minutes. Yeah, they might stop breathing, but they probably won't if they're in loads and loads and loads of pain, and you're an anaesthetist and you can deal with that by poking them and giving them some oxygen. Other times I use fentanyl is in the head-injured person who needs transfer, use it as an induction agent alongside ketamine, etc., but then actually load them up with plenty of fentanyl for that transfery busy period, because it hangs around for a while. It means you're not messing around trying to have an alfentanil infusion and a propofol infusion and then transfer a patient in an ambulance somewhere, because you can just fill them up with fentanyl. And, if you're not waking them up anytime soon, then why worry about it? Fentanyl can also go in other places, like in people's noses and into their epidural space and intrathecal space, but we'll talk about that in a moment. I suppose overall what I'm trying to say is fentanyl good, morphine less good, but people tend to reach for morphine because it's highly familiar. You are going to be a specialist, therefore crack on and use the stuff that you know is better for your patient. Now comes the time in the episode where I vomit verbatim a model answer at you in order to transfer some of that information about this drug to your brain. It might be a bit tenuous, it might be a bit boring, it might be a bit dry, but ultimately, if you can barf this at an examiner, you'll pass the station. Doctor, we've heard your preferred opioid of choice is fentanyl. Could you please
describe and classify and elaborate on the pharmacokinetics of fentanyl? Thank you.
I do like fentanyl actually. So fentanyl is an opioid. It's a synthetic opiate. It's a phenylpiperidine derivative of pethidine actually. It is presented as a clear, colourless liquid. Classically, its concentration is 50 mics per mil, and you can get it in either 100 microgram ampules or 500 microgram ampules. Routes of administration include intravenous, oral, although the bioavailability is quite poor, transdermal, intranasal, intrathecal, and epidural, classically. The dose range is actually exceedingly broad and is particular to the operative intervention. So 1 to 100 mics per kilo, if you're thinking routine general anaesthesia to thoracotomies, for example. Generally speaking, you need 7 to 10 micrograms per kilo to fully obtund the hypertensive response to laryngoscopy. So its mechanism of action is it has a particularly high affinity for the mu-opiate receptor found in the central nervous system. Its actions include pain relief, sedation, and it's also synergistic with hypnotic agents, i.e. propofol. Its onset time, 1 to 2 minutes to start having an effect with the patient, and reaches peak effect within around 5 minutes. Offset about 20 to 30 minutes, so it's a very convenient opiate for short operating times and for patients in acute pain. It does have a side effect profile. Cardiovascular effects include a bradycardia of vagal origin. This is due to sympatholysis. It doesn't affect your systemic vascular resistance or pulmonary vascular resistance particularly. It has a respiratory depressant effect, as do all opiates, and in very high doses there has been some occurrence of the wooden chest phenomenon, or chest wall rigidity. GI effects, it drops your gastrointestinal motility and reduces acid secretion, also causing sphincter of Oddi closure. This may play an importance in HPB surgery. Classic CNS effects would be mild sedation, the meiosis that you'd expect with opiates, i.e. small pupils, and pain relief. From a metabolic perspective, high doses can ease the stress response associated with surgical intervention. This might play a useful role in very large operative procedures, i.e. your thoracotomies or your extensive laparotomies. As I mentioned earlier, it's got poor oral bioavailability, about 33%. It becomes highly ionized in the stomach, causing slow small bowel absorption. Transdermally, its absorption characteristics improve over time, actually. Distribution-wise, it has a pKa of 8.4, so 9% of the drug is unionized at physiological pH. It has quite a low volume of distribution, 4.4 litres or 0.88 kilos per litre. Fentanyl is highly protein-bound, 81 to 94%, but is exceptionally lipid-soluble, which probably provides most of its onset characteristics. Classified as 600 times more lipid-soluble than morphine, which is remarkable, really, isn't it? Metabolically, it is its effects are prolonged in patients with liver disease or renal disease. CYP3A4 is involved in its metabolism. It undergoes N-demethylation to norfentanyl, which, along with fentanyl being hydroxylated, both excreted into the urine. And its clearance rate from the plasma is 13 mils per kilo per minute. The half-life of fentanyl is 140 to 850 minutes, depending on the infusion time. Remember, it has a high context-sensitive half-life time. The more you give for longer, the more you fill the patient, and therefore the longer it takes to all eke out. So that's the crux of the core content that they might want you to know and understand, and obviously these points are relevant in your SBAs as well, when they're going to be asking you, what is the volume of distribution of this compared to this, or what's more likely than that compared with that? Fun times for you. Anyway, moving on to a few more notes and pearls about fentanyl. Other notes of regards to fentanyl. When administered intrathecally or epidurally, it has a very low odd of causing respiratory depression due to it being so exceedingly lipophilic. Why would it go on an adventure out of the nice fatty epidural space or fatty CNS space? Remember, the CNS is nice and fatty. why would it bother going on distal adventures when it can soak in where it's put quite quickly? That's how I imagine it. So it causes less respiratory depression than morphine. From a metabolism breakdown clearance perspective, there is a suggestion that there's some enterosystemic recycling of the drug, i.e. you metabolize it, secrete it via bile into your GI tract, you reabsorb it as it has undergone changes in your GI tract, and then it has an effect again, although minimal. Other things to think about from a kinetics perspective, a single dose redistributes quite quickly, i.e. it wants to go and equilibrate throughout all of your fat stores in your body, depending on which compartment has the greatest blood flow over time. So the effects of fentanyl drop off as it's redistributed, much like the behaviour of propofol. With regards to wooden chest phenomenon, your inhibitory interneurons in your spinal cord that at high doses become affected by opiate receptor binding on them, and this leads to a paradoxical increase in chest wall tone, get wooden chest, and it's then really hard to ventilate the patient until you paralyse them. Sometimes this is seen in mega high doses of remifentanil as well. Naturally, the offset time is faster with remi than fentanyl, but not fast enough that you can't ventilate someone for 10 minutes. You might be finding yourself sweating quite a bit and reaching for the paralysing agents. So now we're going to ponder and talk about this G-protein coupled receptor, of which MOP, DOP, COP, and NOP are all associated. When something, i.e. a ligand, binds to the receptor site on the G-protein coupled receptor, knowingly there are endogenous versions of things that bind to that, i.e. endorphins, enkephalins, these things called dynorphins, don't ask. Opiates bind to them, but also remember naloxone also binds to these receptors. A number of things occur within the cell. So you bind your ligand to your G-protein coupled receptor. This undergoes conformational change across the cell membrane. Remember, these GPCRs are transmembrane, and they have 7 transmembrane crossing points described as being serpiginous. I'm sure you remember all that from medical school. A number of things occur. So voltage-sensitive calcium channels close. The cell becomes hyperpolarized by potassium efflux from the cytoplasm into the extracellular space, and adenyl cyclase inhibition occurs, leading to reduced cyclic AMP available within the cytoplasm. These processes, the sum of, result in inhibition of transmitter release between the nerve cells. So, breaking these receptors down, remember we've got MOP, DOP, COP, and NOP. Your DOP does pain relief and causes respiratory depression. Your COP causes pain relief, sedation, and the meiosis that you see, those small pupils. And then your MOP, handy again, analgesia, causes meiosis, but also is associated with the euphoria, that floaty good feeling, can cause respiratory depression, is involved in the sympatholysis, the bradycardia, and unfortunately also an inhibitor of gut motility, so makes it more constipating. The NOP receptor, which was initially found and wasn't really terribly well classified, has been identified to bind to a chemical considered nociceptin or orphanin. These things don't bind to your mu, delta, or kappa and are associated with this suggestion of increased pain. It acts in the spinal cord and supraspinally, and produces hyperalgesia at low doses, but analgesia at really high doses. Interestingly, buprenorphine has a partial effect on your NOP receptor. It might be that that's its role in reducing opiate tolerance, or morphine tolerance, we maybe should say, in those who are afflicted with opiate addiction. So that's talking quite a lot about fentanyl, and we've covered the receptors and how they work. Other things to think about, or other things to consider when using fentanyl. 100 mics of fentanyl behaves a bit like 10 milligrams of morphine in terms of pain relief. Fentanyl is perhaps a better choice in patients with renal failure compared with morphine, because of the primary hepatic clearance really of fentanyl. That's because it undergoes that N-demethylation we mentioned and ongoing hydroxylation of those components. And there are no active metabolites of fentanyl, whereas obviously there are the morphine 3 and morphine 6 glucuronides that are active metabolites of morphine. So fentanyl probably better in a renal failure patient. If you're really picking something that's only hepatically cleared, then that's buprenorphine, but it's not one that tends to be really used. That dose range of morphine was a point that really confused me when I started. I was reading all these books like 0 to 100 mics per kilo, God what? And being quite flabbergasted that everyone was just using 100 micrograms or 70 micrograms on their patients and wondering what on earth I'd read. It took me a while to realise that actually in things like cardiothoracics, long cases that are exceptionally stimulating in patients who might be a bit crumbly crusty with a knackered heart, humongous amounts of fentanyl as a larger component of your anaesthetic maintenance and induction lead to more stable patients, and you might be horrified to find that they give like a I don't know how many 500 mics, like a milligram of fentanyl, which is tons. They might just be like, here, have this 500 mic ampule, and then have another 500 mic ampule. Go nuts! They're not going to wake up till Tuesday. The thing that was briefly mentioned during all that blurb was PKA. This is something that is good to learn for each of the chief opiates because it gives you some context about their onset times. Fentanyl is a bit of an interesting outlier in this regard. Its pKa is 8.4. Remember, pKa is the pH at which 50% of the drug is ionized and 50% is unionized. The unionized bit is the bit that can jump across fatty membranes with ease. So fentanyl, pKa 8.4. When you shift that down to a physiological pH of 7.4, 9% of it is unionized, which is really actually a very small amount of drug. This is tremendously countered by the lipid solubility, and that's what really achieves the excellent onset time of fentanyl, is it just piles through that fattiness because of the chemical nature of the compound. We're going to go into a bit of a deeper dive of pKa in the next run of podcasts, which are going to focus on some of the pharmacokinetic concepts that have come up during these conversations on rocuronium and fentanyl and propofol. We're going to think a bit about volume of distribution, we're going to think a bit about pKa, and go from there. If you found it useful or awful, please like and subscribe and rate the show. Definitely check out the show notes for those diagrams and the detail of this content. It is a bucket of content to get to grips with. Keep working at it, and you will get better, faster, and stronger. It is vital to keep your interest live for the science that we're covering and not overcook yourself. You will be amazed by what you know come exam day. Don't freak out. Keep studying.